Okay, let's dive in. Think about your knee for a second. There's this tiny C-shaped piece of cartilage inside, the meniscus. Seems small, right? But when it gets injured, wow, it can bring your world to a screeching halt. Doesn't matter if you're like a top athlete or just trying to walk up the stairs pain-free. Today, we're getting into something really significant, a new international effort, the Formal EU-US Meniscus Rehabilitation 2024 Consensus Part 2. And this isn't just, a few doctors sharing ideas. This is a huge project, experts from multiple countries working together. They're trying to pull together the very best knowledge we have right now on preventing, treating, and recovering from meniscus injuries. And there's a big focus on avoiding surgery where possible. This could really change how you think about knee health.
It's fascinating, really, because meniscus injuries are so common. I mean, almost everyone knows someone who's had knee issues, right? But despite that, there's been this kind of a gap in really clear, agreed-upon advice for the rehabilitation part. Surgery techniques have moved on, but the roadmap for recovery, a bit less defined. So this consensus, it steps right into that gap. It gives these really comprehensive recommendations built by surgeons and physical therapists from all over. It's a big deal for bringing clarity.
Right. So our mission today is to unpack this huge document. We want to translate all the medical talk into insights you can actually use. We're going to pull out the most practical, impactful stuff for you, the listener. Get ready for some maybe surprising facts, some aha moments that might genuinely shift how you approach knee health, whether you're injured now or just want to stay healthy. Okay, so let's start with the basics. What exactly is the meniscus? Why is it such a big deal for our knees? Because your knee isn't just a simple hinge, is it? It bends, sure, but it's way more complex. You actually have two menisci in each knee, medial on the inside, lateral on the outside. They're these tough, sort of rubbery, C-shaped bits of cartilage. Think of them like little crescent moons sitting between your thigh bone, the femur, and your shin bone, the tibia.
And they have two main jobs, really critical jobs. First, they're amazing shock absorbers. Every step, every jump, every twist, they cushion that impact, protecting the bone underneath. And second, they add stability. They help spread the load evenly across the knee joint and stop it from wobbling around too much.
So when one of those tears, ouch, you get pain, swelling, maybe that feeling like your knee might give out, and it makes moving your knee incredibly difficult, which, impacts pretty much everything. Walking, sleeping, playing with kids, you name it.
Exactly. And building on that, the consensus really highlights how much the whole approach to managing meniscus problems has changed over time. Historically, meniscectomy, that's surgically removing part or sometimes even all of the meniscus, was incredibly common. One of the most frequent orthopedic surgeries done globally.
Yeah, it seemed like the go-to fix for a long time.
It really was. But the document points out that even with the modern version, arthroscopic partial meniscectomy, that's the keyhole surgery, less invasive than the old open surgeries, the long-term results are described as heterogeneous.
Heterogeneous, that sounds like a polite way of saying inconsistent, mixed results.
That's exactly it. It means variable, unpredictable. Some patients might do great after surgery, get back to everything, but others, they might still have pain, or maybe they develop osteoarthritis in that knee faster than expected years later.
So that variability, that inconsistency, it really tells us something, doesn't it? That just cutting out the damaged piece isn't always the magic bullet.
Precisely. It suggests this big shift in thinking. Preserving the meniscus, trying to save it whenever it's clinically possible, that's become a really key concept now. The guidelines for when to intervene are much clearer, more nuanced. Non-operative management, like physical therapy, is now strongly favored for degenerative lesions, the wear and tear type. Surgical repair is considered for certain traumatic tears, and replacement, only if really specifically indicated. It's a definite move towards being more conservative, preserving your natural knee structure.
And the consensus makes this really crucial distinction between the types of meniscus issues. This seems fundamental to the whole treatment plan. They talk about traumatic meniscus injuries, those caused by a sudden acute event, right?
Exactly. Like that classic story. Playing sports, sudden twist, you hear or feel a pop, sharp pain, immediate swelling. That's your typical traumatic injury.
Okay, and then the other type.
Then there are meniscus lesions. These are defined more as degenerative changes, things that happen slowly over time. More like wear and tear, the cartilage fraying gradually, not one specific ouch moment.
Right, like the fibers of a rope slowly wearing thin.
That's a great analogy, and this distinction is critical, not just academic. It really dictates the treatment approach. For those traumatic tears, surgery might still be on the table earlier. But for the degenerative ones, as we'll get into, that non-operative path, physical therapy, is almost always the first thing recommended. It's a totally different starting point based on how the problem began.
Okay, that makes sense. So given that shift, and knowing there were already two consensuses focused on the surgical side of things, why was this specific consensus, part two, needed now? Especially focusing so much on rehabilitation. What gap is it filling?
That's the core issue. The document itself says that even with those surgical guidelines in place, there was limited evidence and some controversial topics, specifically about the rehabilitation phase. Rehabilitation is massively important, right? For getting back function, preventing future problems, but it just hasn't had the same level of clear, unified, evidence-based guidance that surgery has started to get. There were gaps, areas of debate.
So this consensus aims to fill that void.
Precisely. It aims to provide these robust, internationally agreed-upon recommendations for rehab, whether you've had surgery or you're being managed non-operatively. It kind of completes the picture, giving detailed advice on that crucial recovery period, no matter which path you start on.
It sounds like a massive undertaking. You mentioned it was international. Who exactly was behind pulling all this expertise together? This wasn't just a small committee.
No, definitely not. It was a huge collaborative effort, truly global, a joint project between three major players in the orthopedic and sports medicine world. You have ESSKA, the European Society of Knee Surgery, Sports Traumatology and Arthroscopy, then AOSSM, the American Orthopedic Society for Sports Medicine, and AASPT, the American Academy of Sports Physical Therapy.
Wow, that's a powerhouse group. ESSA, AOSSM, AASPT. That signals a serious commitment. How many experts did they actually get involved?
They brought together 67 experts from 14 countries, and it was a deliberate mix, orthopedic surgeons and physiotherapists. That blend is so important, isn't it? Having both the surgical perspective and the rehab perspective working together for a truly holistic view, it avoids looking at the problem from just one angle.
Absolutely. 67 experts.
Yeah.
How did they actually create these recommendations? I mean, getting 67 experts to agree on anything sounds challenging. Was it just a show of hands?
Far from it. They used a very structured, rigorous process called a formal consensus methodology. It wasn't casual at all. First, there was a steering group of 26 members. Importantly, it was split evenly. Half physical therapists, half surgeons. Their job was to set the key questions the consensus needed to answer, screen all the existing scientific literature, a huge task in itself, and then draft some initial statements based on that evidence.
Okay, so a core group did the initial heavy lifting, digging through the research and proposing the first round of ideas.
Exactly. They laid the foundation. Then they brought in an additional, larger international rating group of 41 members. These experts then assessed the statements proposed by the steering group. They used a 9-point Likert scale, 1 meaning totally inappropriate, 9 meaning complete agreement. And this wasn't just a one-shot deal. They did it in 2 rounds. If there were statements that didn't get strong agreement initially or where there was disagreement, those were discussed. The experts debated, refined the wording, and worked towards resolving those differences. It's a robust way to build genuine agreement.
That does sound thorough. And they also assign grades to the recommendations we see, grade A, B, C, D mentioned. This seems really useful for understanding how solid the advice is. Can you break down what those grades mean for us, the listeners?
Yes, this is absolutely vital for interpreting the consensus properly. It tells you the strength of the evidence behind each statement. Grade A is the top tier. It means there's high-level scientific support, usually from multiple good quality studies like randomized controlled trials. It's strong evidence. Grade B indicates scientific presumption. There's good evidence, but maybe fewer studies, or the studies have some limitations. Still pretty solid. Grade C points to a low level of scientific support. The evidence might be limited, maybe from smaller or less rigorous studies. It suggests something, but isn't definitive proof. And grade D means the recommendation is based on expert opinion.
Okay, grade D, expert opinion. So that means it's valuable because these are top experts, but the hard scientific studies might still be lacking.
Exactly. It doesn't mean the recommendation is weak, necessarily. It reflects the collective wisdom, the clinical experience, the informed judgment of people who deal with this every single day. But it also highlights areas where more research is definitely needed. For now, though, it's the best guidance we have from the people who know the most.
That's a super clear system. So looking at the whole picture, what did they find about the overall level of evidence, specifically for meniscus rehabilitation? Was it mostly grade A and B, or did they lean heavily on that grade D expert opinion?
Well, the results were quite revealing. They found that overall, there was a low to moderate scientific level of evidence available in the current literature for meniscus rehab. Think about this. Out of the 23 statements they evaluated for this Part 2 consensus, Only 3 got a grade A, 4 got a grade B, 3 got a grade C, and 13, more than half, received a grade D.
13 out of 23 based on expert opinion. Wow. So that really underscores your point. A lot of the practical guidance right now comes from the hard-won experience of these clinicians rather than a mountain of perfect scientific trials.
Precisely. It really highlights where future research needs to focus. We need more high-quality studies specifically on rehab strategies. But, and this is important, despite those varying evidence levels, the consensus process itself was highly successful. They achieved 1 strong and 17 relative agreements across the statements. The overall median score was 8 out of 9. That shows remarkable agreement among the experts on these key points, even if the underlying research is still catching up. That shared understanding is powerful in itself.
Okay, that gives us a great framework for understanding the recommendations. Let's shift gears now to prevention. Can we actually prevent meniscus tears, or are they just bad luck, especially if you're active?
That's the million-dollar question, isn't it? The consensus points out that there are no specific meniscus injury prevention programs that only target the meniscus. You can't just do meniscus exercises. However, and this is the key, the evidence we do have comes from broader knee injury prevention programs, often those developed to prevent ACL tears.
Ah, okay. So programs designed for general knee health, or ACLs, can still help protect the meniscus, even if that's not their primary label.
Yes, exactly. Because it's all connected. The consensus suggests that lower extremity injury risk reduction programs focusing on neuromuscular control exercises can be used to prevent overall lower extremity injury. Neuromuscular control is basically about training your brain and muscles to work together better to stabilize your joints during movement. They mention specific programs like the Prevent Injury and Enhanced Performance Program, PE, FIFA11 Pluset, and a Swedish program called Neck Control as useful examples.
PP, FIFA11 plus Connect Control. Can you give us a practical example? What kind of exercise are we talking about in those programs that helps with this neuromuscular control?
Sure. Think about exercises that challenge your balance and coordination, especially when landing or changing direction. Things like single leg squats, plyometric jumps where you focus on landing softly and controlled, or agility drills involving quick side-to-side movements. These teach your muscles to fire at the right time with the right force to protect the knee joint during those risky movements. Now, these specific programs get a grade C recommendation for meniscus prevention, so the direct evidence isn't super strong yet. But their overall benefit for reducing lower limb injuries is generally accepted.
Got it. So focusing on balance, control, and proper landing mechanics is key. Now, the flip side. What activities significantly increase our risk? Where does the consensus say the danger zones are?
This is where we get a grade A recommendation, strong evidence here. For athletes, it's pretty clear. Participation in repetitive cutting, pivoting, and landing activities. Think sports like basketball, soccer, football, netball, even skiing or tennis. Those quick changes of direction, sudden stops, awkward landings, they put a lot of twisting and compression force through the meniscus.
Makes sense for athletes.
Yeah.
But what about everyday life? What about jobs or activities that aren't necessarily high-impact sports? Does the consensus address those risks too? Because knee pain isn't just an athlete thing.
Absolutely, and this is a really important point they make. Highlighting risks often overlooked. The consensus is very specific, another grade A finding. Work-related lifting and carrying, over 10 pounds, 4.5 kilograms, kneeling, deep squatting, and a high volume of climbing has increased risk of meniscus injury. So think about occupations. Construction workers, plumbers, electricians, carpet layers, gardeners, mechanics, even nurses or childcare workers who might do a lot of lifting, kneeling, or squatting. The cumulative stress from these daily activities can lead to degenerative changes or increase the risk of an acute tear. It's not just about the weekend warrior, it's about daily biomechanics too.
That's a huge takeaway. Lifting, kneeling, deep squatting, lots of climbing. Things many people do every day without thinking about the potential knee stress. Okay, let's move into treatment. Many people hear traumatic meniscus tear and immediately think surgery. It seems like the default assumption. But the consensus looks closely at non-operative options, even for these sudden tears. What did they find?
This is where things get really interesting and challenge some assumptions. They found that research specifically investigating non-operative treatment for traumatic tears is actually rare. So there's not a huge amount of high-quality data comparing non-surgical approaches head-to-head with surgery for these acute injuries. This means that while going conservative might be an option, the actual criteria for deciding who should have surgery versus who should try rehab first for a traumatic tear are not well established. There's a need for clearer guidelines based on evidence.
That is surprising. So it's not like there's a simple checklist right after an injury to decide the best path.
Not quite, it seems. It's often more complex. However, the consensus does highlight something very important, based on grade A evidence from two specific studies. These studies looked at patient-reported outcomes, basically, how patients felt and functioned. And they suggested that both surgery and exercise therapy are viable treatment options for traumatic and non-traumatic meniscus tears. Unquote. So from the patient's perspective, a structured exercise program could lead to results similar to surgery for some people, even with a traumatic tear.
That's a powerful finding. Exercise therapy being comparable to surgery in terms of how patients feel. But are there specific types of traumatic tears where surgery is still strongly recommended, where maybe exercise therapy isn't enough?
Yes, there are situations where the experts lean towards surgery. This is based on grade D evidence, their collective clinical opinion. They suggest that more severe symptoms and larger tears may benefit from surgical intervention. Specifically, they mention tear types like bucket handle tears. These are large tears where a piece flips into the joint, often causing locking. Also, complete radial meniscus tears, the tears that go right across the meniscus, disrupting its structure significantly. And things like extended ramp lesions or meniscal root tears, these affect the attachments and stability of the meniscus, especially concerning in younger, active patients. These types of tears often compromise the meniscus's function so much that earlier surgical intervention is thought to give a better chance of restoring stability and preventing further damage.
Bucket handle, radial, root tears.
Yeah.
Okay, those sound mechanically quite disruptive. What about other factors? Does a person's general health, their weight, their job influence how well non-operative rehab might work for a traumatic tear?
Well, the consensus is upfront that hard evidence directly linking specific factors to success or failure of non-op rehab for traumatic tears is lacking. Again, more research needed here. But based on expert opinion, grade D, they suggest several factors may play a role. Things like your lower extremity alignment, how your legs are built, your body mass index, BMI, any medical comorbidities, other health issues you might have. Also, psychosocial and socioeconomic factors, whether someone uses tobacco products, their age, occupation, how well they comply with the rehab plan, and their general level of activity. And of course, factors related to the knee itself, like having high-grade osteoarthritis, OA, already present, and the specific type, location, and magnitude of the meniscus tear. It's a whole constellation of factors that can influence the outcome.
It sounds incredibly complex, really personalized. So if someone does go down the non-operative path for a traumatic tear, what kind of specific rehab interventions do the experts recommend? What does that therapy actually look like?
Again, based on expert opinion, grade D, the focus is on interventions designed to tackle the main problems. Resolve knee effusion, get the swelling down. Reduce pain. Restore quadriceps strength, get that big thigh muscle firing properly. And regain joint-specific motor control. They list several tools that therapists might use, things like cryotherapy, basically, ice or cold therapy, different types of exercises, open and closed kinetic chain exercise, think leg extensions versus squats, modalities like TENS, transcutaneous electrical nerve stimulation for pain relief, or NME, neuromuscular electrical stimulation to help activate muscles, and even exercise with blood flow restriction, or BFR, which is becoming more popular. These are all potential components of a rehab plan.
It's quite a toolkit. With any one of those methods singled out as being the best or most effective for traumatic tears?
No, the consensus is clear. There is no evidence comparing rehabilitation modalities head-to-head for traumatic tears. So we can't say ice is definitively better than TENS, or one exercise type is superior to another based on current research. It likely depends on the individual patient. However, they do highlight one specific study, a single 2024 study, the DREAM trial. This got a grade B rating. This trial found that for traumatic meniscus tears in stable knees, a program of supervised neuromuscular and strength training along with patient education produced similar self-reported outcomes to surgery with the same rehabilitation program.
Okay, hold on. Similar outcomes to surgery, just with supervised exercise and education for traumatic tears in stable knees. That sounds huge.
It is a very significant finding. It suggests that for the right patient, someone with a traumatic tear but whose knee is fundamentally stable, a well-designed, supervised exercise program can be just as good as surgery in terms of how they feel and function. It really empowers the non-operative approach.
Absolutely.
Yeah.
But are there specific proven protocols for how to do that exercise therapy non-operatively?
That's the caveat. While the DREAM trial showed it can work, the consensus cautions that there is no current evidence comparing evidence-based treatment protocols for treating acute meniscus tears non-operatively. So, we don't yet have multiple studies confirming Protocol A is better than Protocol B for this specific situation. When choosing the non-operative path, the recommendation, grade D, is to follow criterion-based milestones like those followed for post-operative meniscal repairs. Meaning progress isn't just about time passing, it's about hitting specific goals, achieving full range of motion, reducing swelling to a certain level, regaining a certain percentage of strength compared to the other leg, performing functional tasks without pain. It's goal-oriented.
Criterion-based, not just time-based. Makes sense. What about where the rehab happens? Is going to a physical therapy clinic better than just doing exercises at home for these traumatic tears?
Again, the direct comparative evidence is missing. The consensus notes no current evidence comparing outpatient rehabilitation programs to home exercise programs, specifically for non-operative management of traumatic tears. However, the grade D recommendation, based on expert opinion, leans towards a combined approach. They suggest that supervised rehabilitation, working with a therapist on range of motion, swelling, strength, function, and control, in addition to a home exercise program, may be recommended. So the ideal seems to be getting that professional guidance and hands-on help, but also being diligent with your exercises at home for the best results.
Okay, that covers the traumatic tears really well. Now let's pivot to the other main category. Degenerative meniscus lesions. These are the slower wear and tear type changes. Is surgery the default here, or does that non-operative first approach really take center stage?
This is arguably one of the strongest and most practice-changing messages in the entire consensus. And it comes with a grade A rating top-level evidence. They state very clearly, degenerative meniscus lesions can be treated with comparable results with either non-operative, including physical therapy, or surgical approach. And therefore, non-operative treatment, including physical therapy, should be the first approach.
Wow, should be the first approach. That's incredibly definitive. Comparable results to surgery, but without the surgery. So for people with that nagging chronic knee pain potentially linked to wear and tear, physical therapy isn't just an option, it's the recommended starting point.
Absolutely. It fundamentally shifts the initial conversation away from surgery for a huge number of patients. The consensus references previous surgical guidelines, which recommend trying 3-6 months of non-operative treatment prior to surgical decision-making. Okay. Give physical therapy and conservative measures a really good shot first. Let the body adapt and respond. Only if symptoms persist despite that dedicated effort, then maybe consider arthroscopic partial meniscectomy. But it's clearly positioned as a second-line option for degenerative lesions.
3 to 6 months trial first. That's a significant commitment to conservative care. But can doctors predict who's likely to succeed with just rehab for these degenerative lesions? Or is it still a bit of try it and see?
That's still a challenge. The consensus acknowledges this is an area needing development. They state that prognosis classifications assessing severity of degenerative meniscus lesions and severity of symptoms are missing and needed. We don't have great tools yet to reliably predict upfront who will do brilliantly with PT and who might eventually need surgery. This is a grade D, finding the experts recognize the need. Ideally, having such classifications would help determine the timing of surgery more effectively for those who ultimately need it. For now, it often involves starting conservative and monitoring progress.
Okay. Are there factors that might suggest someone could have a tougher time succeeding with rehab for a degenerative lesion? Things that might make it less likely to work?
Well, the consensus says there's technically no evidence to support or refute specific factors making rehab more or less successful for degenerative tears. However, leaning on expert opinion again, grade D, they suggest a few things might negatively influence outcomes. These include having high grade of OA, significant arthritis already in the knee, having a high BMI, or having a longer duration of symptoms if the pain has been there for a very long time, perhaps indicating more ingrained changes. These might make the rehab journey potentially more challenging.
Makes sense. So if physical therapy is the first approach, what does that rehab actually involve for degenerative lesions? Is it similar to the traumatic tear rehab?
There's overlap, but the emphasis might be slightly different. The grade B rating, scientific presumption, the consensus suggests a combination of things. Manual therapy, those hands-on techniques from the therapist. Joint mobilization techniques to improve movement. ROM exercises. Critically, progressive knee and hip musculature strength training, strengthening the whole kinetic chain, not just the knee, and neuromuscular training for balance and control. They also mentioned that neuromuscular electrical stimulation, NMES, can be added, if needed, maybe to help activate weak muscles.
And the home exercise component. Still important here.
Absolutely essential, especially for managing a chronic condition. The consensus states home-based exercise programs should be added to supervised physical therapy. Consistency is key. They also mentioned a couple other adjuncts, both grade D, expert opinion. Blood flow restriction training, BFR, can be used to enhance early strengthening efforts, especially if pain limits heavier loading. And knee bracing can be considered, perhaps for symptom management or a feeling of improved stability during activity.
Okay. And just like with traumatic tears, is supervised outpatient rehab proven to be better than just a home program for degenerative lesions?
Similar situation here. The consensus notes that these two approaches have not been compared directly in research for degenerative lesions. So the grade D recommendation remains similar. Supervised rehabilitation for ROM, effusion management, muscle strength, knee function, and neuromuscular control, in addition to a home exercise program, may be recommended. That combination of professional oversight and personal diligence seems to be the favored approach based on clinical experience.
The consensus is heavily focused on rehab, naturally. Did it touch upon any other non-operative treatments people might hear about for degenerative knee pain, even briefly?
Yes, it did acknowledge them. It stated that rehabilitation is not the only non-operative treatment option. It listed things like rest, taking non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen, or getting intra-articular or perimeniscal injections, maybe corticosteroids. But it quickly clarified that these treatments were out the scope of this consensus and weren't discussed in detail. The focus remains squarely on the rehabilitation component.
Got it. Okay, let's talk about the finish line for many people. Return to sport, or RTS. Whether it's elite athletics or just weekend hiking, getting back to activity is often the main goal. What does the consensus say about how to manage that process?
The key principle, according to their grade D recommendation, is that RTS management should be criterion-based and time-based. It's not just about hitting functional goals, and it's not just about waiting a certain number of months. It's a combination. You need to meet the physical criteria, and enough time needs to have passed for biological healing, especially after a repair.
Criterion-based and time-based. So what are those key criteria someone needs to meet before they get the green light?
It's a comprehensive assessment. They look at subjective and objective knee function, physical and psychological factors. So, subjectively, how does the knee feel to the patient? Pain levels, confidence, objectively, measuring range of motion, ROM, checking for joint effusion, swelling, testing quadriceps and hamstring muscle strength and activation, usually comparing the injured side to the uninjured side. They also emphasize performance-based parameters, things like hop tests, agility drills, assessing coordination and stabilization under load, and importantly, they include patients' motivation and readiness to return to sport. The psychological piece is crucial. Are they mentally ready and confident to go back?
The psychological readiness, that's fascinating. They include that so explicitly.
Yeah.
What about general timeframes for returning to sport, particularly after surgery? You mentioned it depends.
Yes, it varies significantly based on the procedure. This is a grade C recommendation. For a partial meniscectomy, where tissue is removed, RTS is typically recommended somewhere between 4 to 12 weeks. But for a meniscal repair where the tear is stitched, it's much longer, 6 to 9 months. That huge difference reflects the need for the repaired tissue to actually heal and mature biologically, which takes considerable time. You can't rush a repair.
6 to 9 months for a repair versus maybe 1 to 3 for a meniscectomy. That's a major difference potential patients need to understand. Does the specific sport matter? Does rehab need to be tailored to whether you're returning to running versus, say, basketball?
Absolutely. The experts, grade D, recommend that sport-specific rehabilitation on the field is recommended to complete the on-field rehabilitation phase. You need to gradually reintroduce the actual movements, stresses, and environments of your specific sport. Running drills for a runner, cutting and jumping drills for a basketball player, specific choreography for a dancer. The specific requirements of the sport do matter when making progressive return to sport rehabilitation decisions. A generic program isn't enough for safe return to demanding activities.
Makes sense. Train for what you're going back to. Are there other factors, maybe about the patient or the initial injury, that influence how quickly or successfully someone returns to sport?
Yes, based on expert opinion, grade D, several factors are thought to be important. The type, location, size of the tear or lesion matters. The type of surgery performed, whether there were concomitant injuries like an ACL tear at the same time, and overall muscle function. These factors might actually be more important factors determining the time to return to sport than just the procedure name alone. A simple tear might recover faster than a complex one, even with the same type of surgery.
Is there ever a situation where returning to sport is just not advised,
Yeah.
where the recommendation is actually not to go back?
Yes, there is a clear point where safety takes precedence. It's a grade D recommendation. If knee function cannot be restored and clinical milestones cannot be met, return to sports is not recommended after a meniscus injury or surgery. If, despite best efforts in rehab, the knee remains painful, unstable, weak, or functionally limited, pushing back to sport risks further injury, potentially permanent damage, or accelerating arthritis. Sometimes modifying activities or choosing different ones is the safer long-term decision for knee health.
A difficult conversation, but a necessary one for long-term health. So throughout this whole process, how do clinicians actually measure progress? How do they know if the rehab is working and if someone is ready to move to the next stage or return to activity?
They recommend using a combination approach, gathering subjective information from the patient using patient-reported outcome measures, PROMs, and collecting objective data through clinical and performance-based tests. You need both pieces of the puzzle.
Okay, let's start with PROMs. Those questionnaires. Which ones did the consensus recommend to get the patient's side of the story?
They suggest using a battery of validated PROMs to get a full picture, grade B recommendation. This includes a disease-specific one like the WOMAC, Western Ontario and McMaster University's Arthritis Index, a knee-specific one like the IKDC, International Knee Documentation Committee, or the KOS, Knee Injury and Osteoarthritis Outcome Score. An activity-related scale like the Tegner or Mark's Activity Scale to gauge their functional level, and a simple pain scale, often the VAS, Visual Analog Scale. Using these together gives a rich understanding of the patient's symptoms, function, activity level, and pain from their own perspective.
So multiple angles on the patient's experience. What about the objective stuff clinicians measure in the clinic?
For objective measures, they advocate a criterion-based approach, grade D. Assessment should include measuring ROM, range of motion, assessing knee joint effusion, swelling, conducting objective strength tests using tools like isokinetic machines or handheld dynamometers to get actual force numbers for muscles like the quads and hamstrings, and performing hop tests like single leg hop for distance or triple hop.
Hop tests seem like a good way to assess real-world function, not just isolated strength. How are those interpreted?
Yes, they're great for functional assessment. They recommend evaluating quadriceps knee extension and hamstrings knee flexion strength objectively. And for those activity-related testing, like hop tests, the key is to interpret them using the Limb Symmetry Index, LSI. This compares the performance of the injured leg to the uninjured leg, expressed as a percentage. For example, if you can hop 80 centimeters on your good leg and only 64 centimeters on your injured leg, your LSI is 80%. Generally, clinicians look for an LSI of 90% or higher on strength and hop tests before clearing someone for return to high-level sport. It's a crucial benchmark for functional recovery and reducing re-injury risk. Also grade D.
Limb Symmetry Index, that's a really useful concept. Finally, during this rehab journey, things don't always go smoothly. When should a patient or therapist know it's time to loop the surgeon back in? What are the red flags?
This is critical for safety and ensuring timely intervention if needed. The consensus provides clear guidance here. Referral back to the orthopedic surgeon is recommended for persistent pain, grade C, pain that just isn't improving as expected with rehab, recurrence of stiffness and/or fusion, grade C, if the knee gets stiff or swells up again after it gotten better, persistent functional instability, grade C, that ongoing feeling of the knee giving way. Mechanical symptoms, grade C, things like true locking, catching, or painful clicking that suggest something is physically blocking the joint. Any unexpected neurological symptoms, grade C, new numbness, tingling, or weakness. And finally, the inability to reach clinical milestones related to knee symptoms, grade D basically, if progress stalls despite good effort. These all warrant a surgical reevaluation.
Persistent pain, recurrent swelling, instability, mechanical symptoms, neurological signs, or just stalling out on progress. Okay, those are really important flags to watch for. This consensus clearly provides so much valuable guidance, but it's also honest about its own limitations, right? What did the experts identify as the main shortcomings or areas where the science is still developing?
Yes, they were very transparent about that. The biggest limitation mentioned is mainly related to limited available evidence supporting some of the statements. As we saw with all the grade D recommendations, many rely heavily on expert opinion because high-quality research specifically on certain rehab questions is still lacking. It's an honest reflection of where the field is.
So knowing that, where did they identify the most critical needs for future research? What questions do we still need to answer definitively?
There's a recognized strong need for more research into the optimal treatment approaches in patients with acute meniscal tears. They note that the very early stage after an acute tear can be tough. Patients often have significant pain and swelling, which might make immediate intensive exercise difficult or impossible. So research on effective early stage interventions is needed.
And what about predicting outcomes better? Being able to tell patients more accurately from the start what their prognosis is.
Exactly. There's a call for better classification systems, systems that would incorporate multiple factors together. The patient's symptoms, the specific type of tear, the presence and severity of any OA, the patient's aimed activity level, and even their expected rehabilitation speed. Having robust systems like this, based on data, would make it much easier to predict who will benefit from non-operative or surgical treatment right from the beginning, leading to more personalized and efficient care.
And comparing different rehab approaches directly.
Absolutely critical. The consensus makes an explicit call for specific rehabilitation protocols to be compared to each other and to surgical options in prospective trials. We need more high-quality studies, randomized controlled trials, ideally, that directly compare rehab program A versus rehab program B, or rehab program C versus surgery plus rehab for specific types of meniscus tears and patient populations. That's how we strengthen the evidence base and turn more of those grade D recommendations into grade B or A in the future. That's where the big advancements are likely to come.
What an incredibly thorough deep dive. We've covered so much, from the basic anatomy and types of tears through the huge shift towards non-operative first approaches, especially for degenerative lesions, the detailed criteria for rehab and return to sport, and where the science still needs to go. This consensus really paints a new picture of meniscus management.
It really does. I think the biggest takeaways are that rehabilitation is highly individualized, it needs to be criterion-based, and crucially, that surgery isn't always the first or only answer, particularly for those degenerative wear and tear type lesions. The emphasis on careful assessment, tailored programs that include strength, neuromuscular control, and function, and listening to patient-reported outcomes is so important. It's a big step for global best practice.
So as we wrap up, think about this journey of meniscus recovery. This deep dive shows us not just what the experts know, but also what they acknowledge we still need to learn. It leads to a final thought for you, our listener. As research continues, how might the even deeper integration of your truly unique factors, your specific job demands, your personal activity goals, maybe even your genetic predispositions or psychological resilience shape the next generation of personalized meniscus care, taking us even beyond these current expert recommendations towards truly individualized recovery pathways?